What do we think we've been optimizing for in the last 20 years? And what have we actually been optimizing for when it comes to emergency medicine?
Well, if we look at large scale incidents, we've moved forward over the last 20 odd years. Many of us were brought up on what we were taught about big major incidents, the decade of disasters,
Mhm.
your Hillsboroughs, your Piper Alphas. It was a tough period of time with a lot of large scale incidents. I think what unfortunately we have done as we've looked at subsequent incidents, 7/7, you know, anything that has come since then, is we have changed systems and doctrine and put more SOPs in. And as a
Mhm.
result, I do worry that we have shifted the focus from the the patient, which should be at the center of what we're trying to deliver care. It's about
Mhm.
saving lives. We've shifted away from that and we've gone on to, have we set up the right command and control aspects? And
Mm.
one of the bits that I've been somewhat criticized for saying this in the past, but I'll stand to it. If you look at the ambulance service and what was NARU, National Ambulance Resilience Unit, they have a set of command and control guidance. And if a major incident is declared, you have to fill all of these roles at, operational and tactical level. And you have all these functional roles of primary triage, secondary triage, parking officer, safety officer. All of these people have to don tabard.
Parking officer. That is true, though.
Yeah, and you end up with what I term an adverse tabard to patient ratio, where all of your clinicians are wearing tabards, carrying clipboards, and not actually saving lives. So what we need to do is create something that is predicated on our core responsibility as a health response, which is saving lives and reducing harm, along the kind of Jessup principles. So we need something that is scalable and is focused on the patient.
Okay, let's try and steel man this argument because I want to romantically agree with everything you're saying, but in the back of my head, if I place it in my world fire and rescue for a second, you get a lot of people. We've had carcinogens and all of this toxic stuff, and we've had firefighter deaths, and we've had
Yeah,
police officer fatalities, and all this sort of stuff. And I always say, okay, well the safest firefighter, the safest first responder, will never go into the hot
yeah,
zone because that's the safest thing to do. Just don't go anywhere near it. But
yeah,
obviously that is juxtaposed challenge of we're supposed to do the thing. But
yes,
in our world, like I'd love to send more breathing apparatus into incidents, but we end up going, we need an engine control this and we need a safety officer that, and then they need like an assistant and a scribe, and then we need a thing and a thing. And then we spoke recently before before chatting here. I've just been over from America, and before that when I was in Australia, some time in Belgium, and they seem to be sending more people in and then trying to have those people at a higher level of like personal accountability and their own safety. But it is very difficult because it's like sphere of influence, sphere of control. The things that are happening with the casualty are somewhat outside of your sphere of control. You obviously influence them by the actions that we take in our command and control systems, but we can just increase complexity on our side, and sometimes
yeah,
that can act like a pacifier, help us feel like. And I'm not saying all of it's performative and useless, but I wonder if the percentage of more stuff we do, how much of it actually is useful and effective in what is the goal that we're supposed to be optimizing for, which is casualty centered or victim centered
yeah,
rescue. Because we do seem to have, as you say, whether it's procedurally, structurally, we made it very, very. I think the thing we do becomes complicated when we interact with the human being. It's complex, isn't it? And we just
yes,
made our bit a bit more complicated.
yes. I think you've tapped into two very big strands for the way that I've been thinking over the last few years.
Mhm.
So I am concerned that we have put our commanders in an unwinnable situation. We are saying you have a duty to care to save lives of those that have been injured in this incident, but you must do that without putting any of your responders at any significant risk. So they are balancing, the right to life against what is the the health and safety regulations. And we do need a degree of safe system of work to be put in there to make sure people are doing things reasonably correctly. But at the end of the day, our duty of care is to save lives. And we have, I think, over the years ended up in a situation where we have not put responders at any risk.
Mm,
So I think
mm,
there has been a degree of risk aversion, and that if we're not putting responders in, that results in the care gap that was highlighted in Section 20 of Manchester
mhm,
Arena Inquiry.
mhm.
That, or as my colleague Claire Park calls it, the therapeutic vacuum, where there is no one in there delivering any care.
That is fantastic. The therapeutic vacuum.
Yeah,
I'm going to
and
write that down. Give me
uh,
a second. I'm stealing that.
yeah,
What's the lady's name again? Sorry.
Claire Park.
Claire Park. What a banging statement that is, Claire. Yeah, I think echoing back to like seeing how things are done in different nations, I think we've shifted from what historically we saw as like reckless heroism
Yes,
to an overcorrected
yes,
caution,
yes,
because historically it was decisiveness, aggression, get stuck in kind of
yeah,
behavior. Sometimes that saves lives. Sometimes it buries first responders. And
yes,
when you hear, I had a guy on from the American first responder community, and he had a big, his thing was about line of duty deaths
yeah,
and saying, it's not your duty to die. You know what I mean? Because of in the UK, Management Health Safety Work Act, health safety regulations, all of this stuff that we have. If you worked in a bread factory, it shouldn't be an expectation that you might get pulled into the oven and die.
yeah,
You're just doing a job as
yeah,
a paramedic, as a firefighter, as a police officer. You're not actually at war. You're not in the
yeah,
army where we go, yeah, well, you might actually get shot at. It's kind of
yeah,
in the thing. So yeah, but certainly in the fire and rescue service, they have a bit this line of duty death thing. They still call it that now. They do do LOD reports. There's websites about it, and he just doesn't like the vernacular,
yeah,
the line of duty death. But then echoing back to the first point is, when does the pendulum swing too far to more
yes,
procedures, more emphasis on justification, rationale? The pendulum just swings too far, and when you increase accountability without equally increasing like decision making confidence, you
yes,
don't necessarily get safer commanders. You get hesitant ones. You get
yes.
timid firefighters, as it
Procrastination.
was procrastination. Yeah, just too much rumination and vociferation about the right decision. And like you do a lot of talking around decision making and distress. And I always say in situational awareness, you're only ever going to get 70-80%,
Oh,
maybe not even that, to be honest with you, because it's a moving target.
yes.
Do you know what I mean? If you waited for certainty, you'd never make a decision.
Absolutely. I think there's a couple of things that we probably don't discuss with our responders when they start with us. And one is this job as an emergency service responder involves some risk. And
Mhm,
I think we have to be honest and open about that
mhm,
at the start. And myself and a couple of colleagues from, including fire rescue colleagues from LFB, were speaking at a conference last week, and we had a number of student paramedics in the audience, and we were talking about taking risk. There is an expectation that some risk will be taken to save lives, and this care gap is not a new thing. It was there, the Derek Bird shooting, Highmore Cross. There's multiple instances in which this care gap happens, and it's inevitable. If you drive your car off a dual carriageway, there will be a period of time before anyone can get to you. It's about minimizing that gap, either by narrowing it, getting in there quickly, or filling it, anyone who is in there delivering some care. Um, so I think we've never really discussed risk. And let's be honest, why are we thinking that risk is only present in these large scale incidents that might involve a threat from an assailant or something? That happens every day when we respond pre-hospitally. We're driving on blue lights. That's not without risk. We
no.
are entering households where people may be violent. That is just part of what we do. So I think we need to um, embrace a degree of being genuine with our responders and saying that this has risk, and what our job is to do is to minimize it, but we can never make it completely safe. Otherwise, you would never get in your car every morning. So
No.
There is a
The
degree of,
car thing is a weird one, isn't it?
yeah,
It's like there's a thin white line separating you traveling 60 miles an hour in one direction or 40 miles an hour, whatever, and
yeah,
some gone, you do no idea. You've never met
yeah,
them. Their life may be falling apart. They're stressed. They're this, they're that. And it's just trust. It's just
yeah,
societal trust. It's
yeah,
an unwritten contract. You stay in your lane, quite literally. I'll stay
yeah,
in my lane. We won't kill each other,
yeah,
whether accidentally or consciously. Um, but yeah, the decision element of it, because if someone hits you in your car, it's like, that's outside my sphere of control. But when it's your decision, it's like, if I act and it goes wrong, I'll be judged. But
yeah,
if I wait, hey, Phil, I was just more information gathering.
yeah,
Just
yeah.
getting a bit more situational awareness, brother, because I'm a
The
professional, Phil, because that's
yeah.
what professionals do. Okay.
The information and the certainty, and I love the fact that you brought up uncertainty. We desperately need to embrace uncertainty at these large scale, fast moving incidents. You will never know everything that you want to know. I take the clinical analogy because being a consultant in emergency medicine and pre-hospital emergency medicine, I am faced with critically ill and injured patients very frequently, but I don't know everything about them. I don't have all their records. I don't have all the blood tests. I don't have that. I have to make a decision with the information that is in front of me. And whether you think this is going into the thin slicing type 1 thinking, recognition, prime decision making, we could talk about the
Mhm.
psychology around it, but that's a little bit too academic.
You're just
But
pattern mashing as
yeah,
quickly as you can.
absolutely.
Likelihood.
Yeah, and
Yeah.
we need to embrace that uncertainty and say, the Colin Powell bit around if you've got a high risk decision to make,
Mhm.
if you wait for 100% of the information, you're too late, and if you make the decision with under 40% of the information, you probably don't know enough, and that
Mhm.
somewhere between 40 and 70%, and then go with your gut, I think is very, very wise. But I don't think we tell people to think like that. We make them
Mm.
information hungry. It's all about,
Mhm.
well, you need to find out more.
Mhm.
Um, and you'll see a lot of it when they say, you've got to get a grip of this incident. Now, information will be coming at you at such a rate from so many different
Mhm.
sources. Sorting the signal to noise ratio, working out what's
Mm.
true information, old information, misinformation, and worryingly in the modern age, a degree of potential disinformation that is being
Mhm.
fed to you. So, when people say, the job of the emergency services when they respond to this is to bring order to chaos. Well, that's fine, but you will never know all the information until weeks later. There's
Mm.
I'm gonna completely mash up a quote from George Peabody, the American philanthropist, who said, the job is not to bring order from chaos, but it is to embrace the chaos and get the job done. We still need to get in
Yeah.
there in the midst of chaos, save some lives, and do it as safely as we can. We have we love putting doctrine in there. We love putting SOPs and dogma and, oh, you must check with command. It's like, if I'm speaking to a remote commander of, is it right for me to do this? It's like me phoning the commander and saying, is it okay to cross the road?
Yeah.
It's utter nonsense. Using a sense check of a wise peer to go, am I seeing the wood for the trees here on
Yeah.
lower time decisions? But at the
Mhm.
end of the day, you need to take the information that's in front of you. And
Mm.
this all goes back to that decision to deploy.
Mhm.
And, you know, we are we are experts in our fields to varying degrees, and we need to allow our responders a certain degree of latitude within guide rails of safety as
Mhm.
to what they do. So, when people say to me, "Oh, you're letting people cavalierly run in," and I'm like, "No, I'm not. I'm not saying this is all about
Mhm.
just running in and saving lives. There needs to be a degree of balance on that. But for me, there's three key principles if I'm thinking of deploying as a responder or deploying my responders. Is
Mhm.
one, are there patients to be saved in there? Can I hear them? Can I see them? Are we getting calls from them? Then there is lives to be saved. Would I go? Would I commit responders to a building in which it was impossible for anyone to have survived with no evidence that there are people in there? No, I wouldn't, because that's too much risk for no benefit. So are there casualties in there? Next one is there a real and present threat in front of me? And people are wise enough to know what a threat looks like. Are there bystanders running towards them screaming? Can they see somebody running around with a knife? Can they hear gunfire? That kind of thing. So there is a degree of your own dynamic risk assessment as to what you're seeing. But for me, the fundamental one is, are there zero responders in there delivering care to these patients? Are there members of the public delivering care to the injured patients within that environment? Because if there are, and you've got emergency service responders, particularly those that may be tactically trained, ballistically protected, why are they not in there? Because we
It's awkward,
cannot.
isn't it?
Yeah, we cannot allow, and I'm really, really proud of what the public does. If you look at the actions of zero responders in Manchester, London Bridge Borough Market, they saved lives. Same from the recent stabbing on the Huntingdon train. The actions of zero responders. I recently did the Westfield Shopping Centre Bondi Junction public inquiry. You look at the actions by the zero responders there in slowing down the attacker, directing the police to the attacker, delivering first aid and guarding victims. And similarly, the Bondi Beach shooting, the bravery of zero responders. We cannot.
The video of that guy that sneaks round the car to just grab. Oh my God! Doesn't he get shot by the sun afterwards or something? Because the sun's on the bridge or something.
I have to say, an incident like that, I wouldn't go picking up a gun, because I think you do change the profile to anyone that's approaching from the law enforcement as to who you are. But the fact that people will make that effort to save fellow humans, and I think another thing within our kind of response plans for whatever emergency service, we never take into account the actions of zero responders. We think of them as a hindrance. Clear them out, get them away to safety. They're told.
Is that because we think we can't control them, or they're not, valid? They're not sort of, we don't know their background? Because you do see in different. I remember going to Vietnam, and in the lobbies, just as a side point, in the lobbies they had these cases with breathing apparatus sets in them, and they said, in the event of a fire, put it on and attempt to make, and they have hose reels and stuff. Whereas here, we're like, don't you dare pick up. Are you extinguisher trained?
Yeah.
Don't you dare touch it. Don't dare touch it.
You're out of date with your fire safety training.
I get a cold burn on my hand, or it squirts water in someone's face.
Yeah.
And I get, I'm speaking from an bias, but I think, well, certainly in my world, or in our world, but certainly then micro in my world, fire and rescue service, a lot of people don't like having them inside a cordon. You see in different states, they'll help, crews run out hoses and stuff like that. I think it's because we think the thing that we do, fire service, is more complicated. But I don't know if there's a slight condescension when we go, oh, well, anybody can help with CPR. Exactly. So anybody can. This is why I don't know why the fire service is so against co-responding. Because I'm like, they're kind of just saying, can you do the defib bit and can you do the CPR bit to the really bad ones until we get there? We'll do the, you guys will do the complicated bit when you get there. But can I do, my daughter that went to Brownies can do that bit.
Yeah.
So why, and I get we're doing it from the pay perspective, blah, blah, blah. But zero responders, do you think we empower the public enough? Should there be more public training and awareness? Because clearly these things are on the rise. Terror and so civil unrest, and God knows what's happening with America now and everybody else. Like, do we need to encourage people to be empowered to take action for their fellow human?
I don't know whether we need to encourage it, because I think people will do it. I think what we need to do is not pretend that that's not going to happen. We tell the public to run, hide, tell, but they don't. They they go and they go
Yeah.
and look after, and it's not just their loved
Yeah.
ones, it's anybody. They will go, and they will go, they'll stop bleeding. I think what we do need to do is educate people in those very early, immediate life-saving interventions like stopping bleeding and opening an airway.
How many how many catastrophic bleed sets are out? Because this is the next wave of stuff going across the UK, isn't it? So obviously we've had defibs and phone boxes and on fire and ambulance stations for a long time now. But
Yeah.
you've seen a lot of catastrophic bleed kits. I've seen a few, but like, would you be able to give any insight into the
So I think
proliferation of them?
there is two aspects to that. There is
Okay.
the kind of government sanctioned public access trauma kits that were recommended from Manchester Arena inquiry.
Mhm.
And those are to be placed in areas of potential high threat. Now that they're areas where people are. So people are going to be the victims of interpersonal violence, even if that isn't a large scale incident. And
Mhm.
then there's these charitable stop the bleed kits,
Okay.
of which there are an increasing proliferation, and the content of those kits often varies. For me, having all that equipment has some potential benefit, but the key bit is actually the basic stuff of, if there is blood coming out, press on it. And what I think we need to do is keep it simple. There is there isn't much evidence from UK civilian practice
Mhm.
that all these bits of equipment will save lives. Now, in the hands of a trained individual, they might do, but that's still actually vanishingly
Are you
rare.
including defibs in that, or are we
Oh no,
specifically focusing on?
I'm
But is that not a
specific.
time thing though? Because defibs have just been around for longer, so maybe people need to get used to these
I,
catastrophic
I
bleed kits,
I
and we need
think
to put
they're
out some more public awareness adverts. I don't know. I have no idea.
So I think public access AEDs, there is definite evidence, because if you are in a shockable rhythm, the only thing that will save you is the defib.
Mhm.
And you need that. And the sooner you get it, the better. There isn't that much evidence for certainly stuff like chest seals and hemostatic gauzes and all these things that are within these kits.
Chest seals I get because they're weird. I'd have thought hemostatic gore. Is it just because people don't know what they are and they don't know want to use them, or?
Well, to be honest, if you just put direct pressure and pack the hole with whatever you have got, that is
Okay.
probably as good as these hemostatic gauzes.
Okay.
We will see, tourniquets for years. When I started training, they were the work of the devil. They were Satan incarnate. We must never put a tourniquet on. And then we get the evidence from military conflicts, in Iraq and Afghanistan, which show that tourniquets save lives because they stop catastrophic hemorrhage. But that was in a system where it is being put on by somebody who is right next to you very, very quickly.
Mhm.
This is not being put on by somebody who arrives 10, 15,
Mhm.
20 minutes
Mhm.
later, after they have had their IR March briefing and deemed where it is safe for them to enter
Yeah.
and
We've
decided
done
what
a couple of
uniform they're
Jessips,
getting.
and then
Yeah,
we're in there and go,
yeah,
"Ah,
they're
I mean, there's a few pints of blood here. Bet
yeah,
they've got a catastrophic bleed." No, they did have one.
yeah,
Now
and
now they just need bloods and fluid because they're basically just
yeah,
on the
and
on the on the exit ramp of life.
yeah, each of these patients has, if you are injured in a large scale incident, you have an egg timer of life, and that sand is trickling away. And you need to have some life saving interventions done as early as possible to slow that flow down. And so you end up with these windows of opportunity in which you need to act to stop the bleeding and open the airway. And if you are waiting outside to be allowed in,
Mhm.
and no one else is in there doing it, you will succumb. And we saw that with the tragic death of John Atkinson at Manchester Arena. He undoubtedly should have survived his injuries. He would have been horrifically injured and probably lost both legs, but he should not have died. He went into cardiac arrest 67 minutes after the blast because of blood loss, because the bleeding was not controlled early on. He was not recognized because he'd been moved and they didn't see the blood. There was all of these
Over an
windows.
hour.
Yeah,
Oh
that
God.
there
That's
was.
hard for the family to hear, isn't it?
Oh, yes. Everybody, I've met many of the victims and the families from Manchester after I gave my evidence, and as part of the group trying to say, we are trying to do better. And every family has such a harrowing story to tell. And for me, whilst that is distressing to listen to, I need to own that, because that is the ammunition, the feed which I can start using to make positive change in the way we respond. So, there are each patient, some unfortunately will be undeniably dead and there will be nothing that we can do. But for those that have potential for their lives to be saved, we need to get in there and act quickly.
Do you think we've got better at paying respect to the tragedy, but still learning from it? Because historically, I can speak again from my sector, we would just say things were such a, there was catastrophic tragedy, oh my God, how hot. Right, on to the next. Do you know what I mean? We weren't always as good as learning because we spoke about psychological safety before we came on, because it's easy to point fingers and go, the terrorist, the thing, the electronic battery, we didn't know about the lithium with this, that, the whatever. Pointing thumbs is
Yeah.
hard and go, well, was I quick enough? Was I there? Why did I
Yeah.
go in the wrong pocket? Why did I go in the wrong bag? Why did I send the wrong resource? Why did it take me 12 minutes instead of 4 minutes to make that decision? Those pointing thumbs is very difficult. We spoke before we came on, just to relate to the individual from the Manchester bombing 67 minutes element. America, where I was just spending time with firefighters, and they now send their fire EMS paramedics in because of the 2 police officers that died serving a warrant, I believe in 2008, and they were fired upon, but they
Yeah.
couldn't send any paramedics in there because it was still an active shooter. And whilst they tried to detain, I don't know how they got hold of the other person, but ultimately the 2 police officers bled out.
Yeah.
And we can sit and go, God, we should be more aggressive at just, subduing casualties. Let's just start opening fire onto unknown doors. Or we could go, hey, maybe we can change something and send our EMS in sooner. So now, as we said before, they
Yes.
have full SWAT gear, they carry a firearm, they're paramedics, and they go in and do the
Yeah.
thing. We look at a lot of American stuff and go, well, stupid Americans, why they're doing this, why they're doing that, why do they love guns so much? But they do, is an example there, and I'm sure you could relay many similar examples for the UK. Stuff like that is a point of thumb, and going,
Yeah.
how do
There's
I do better?
again, 2 great themes there. If we try and to kind of dissect them out a little bit, we are great at identifying lessons, and we identify them at every incident that we have, and they are the same lessons. If you look at Kevin Pollock's report on learning, he just highlighted that, we keep finding the same learning or the lessons. We don't actually learn from it, and that to me was a massive wake up call. I think if I was again stepping slightly towards the controversial end, if you look at the lessons identified from the London bombing 7/7 inquiry, and you overlay those from the Manchester Arena inquiry, there is an awful lot of similarity. Delay in getting to patients, communications that failed, lack of adequate analgesia, lack of stretchers. It's just alarmingly similar. And is it because all of these are addressing the system, not the patient? Now, I think people become very concerned about the marauding terrorist threat, the firearms threat. We have our MTA, joint operating principles. If you look at other places like Australasia, again relating to the Bondi incidents, they have armed active offender, which is a slightly different nomenclature, but everyone is taught what they should do. And well, okay, that might be the hot zone and you don't want to go in there. Look at the speed in which these incidents happen. So every UK incident, Southport about 13 minutes, London Bridge Borough Market 8 to 10 minutes, depending if you count the deliberate vehicle attack component, Huntingdon stabbing 10 minutes. All of these things are relatively short-lived. If you look at US active shooters, the median time for an active shooter incident is 4 to 6 minutes. Very few of them last more than 10 minutes. Even if you look at the Harvest Festival one, that was just over 10 minutes, but an immense amount of ammunition released in that point. The protracted incidents are pretty rare. So you look at the Paris attack, and the only real long part of that was the Bataclan, which was a siege. You look at Utoya, and again, that was the equivalent of a siege. You can't get to me. I am able to deliver harm here because I cannot be, I cannot be dealt with. But the vast majority of these incidents are so dynamic and fast moving, they will be over and done within 10 minutes. And if you are sat there waiting for a commander to arrive and tell you what to do, those patients will be dying in that time. As my colleague from the US, Farouk Mekri, says, the stars and the bars will still be in their cars. You just need to think about the fact that we need to do something to save those lives. And I'm not saying you just rush in, but there needs to be something a little bit more of that mission command Auftrag tactic. We know what we've got to do, and that's save lives. Let's get on and do it as best we can before we are told exactly what we must do.
Well, I don't want to misquote anything, but that is, again, I think, and you'll know better than me, the Manchester element from the fire perspective. The stars and the bars were still they were traveling around trying to make decisions from a long ass way away.
Yeah.
Do you know what I mean? And if I zoom that down to the micro, people understand the silliness of it. Silliness is an offensive word. What I'm saying is, like, when I send a breathing apparatus team into a house, if they call me from the inside and go, hey, boss, the ABC XYZ, I'm like, make your own decision. I can give you external factors. So, wind direction, this, I can see this, I can see that. Once you pass the threshold of that door, I can't see what you're doing. You've just become your own incident commander in that scene.
Yes.
Your level of situation awareness. So your argument is my level of training is better, and I have an external situational awareness, but I don't know what's going on in there. If you tell, like, if we zoom right down, and I'm very poor at relating this internally for a paramedic, but if they go, should I administer this? Should I administer? I don't know. You're seeing it better than I am, and that's there's an empowerment thing to that, but it is really uncomfortable when you said about the similarities of previous incidents. They say history doesn't repeat itself, but it definitely rhymes, which is really, we can do the Lacknell House, Grenfell comparisons. There's lots in our world where we go, you know what I mean?
I think what we tend to do is focus on the detail and then try and write an SOP or a bit of doctrine to overcome that detail, whereas we should be looking more at the philosophy of what
are we solving
doing.
for symptoms and not causes, do you think?
Yes.
Okay.
Yeah.
So how do we solve for causes? So elements like, is this an appropriate segue for something like the 10-second triage? Because that is more of a big template, or is that a micro? I'm trying to think where this sits in that.
I think there is a lot of that philosophy that myself and the team that created 10-second triage embraced. Okay. We recognized that the pre-existing triage tools that we used were too slow to save lives when you are faced with a large number of patients. So if you are one of those two British Transport Police at Manchester Arena that ran into the city room within 2 minutes of that blast going off, and you are faced with 300 plus casualties in that room, you cannot start going around every one of them and trying to, take a pulse and a blood pressure and, respiratory.
Was that the previous expectation then?
Well,
sorry to interrupt. How did you know the old systems?
Well, previously it was only ambulance service can triage because they're clinicians. You can't let anyone else triage, and we ended up with this kind of weird dichotomy whereby you had casualty care, fire rescue people, police medics, particularly within firearms under the D13 guidance, were trained in the early life-saving interventions on people. And the ambulance service coming in and being asked to triage people, the old systems had a couple of problems. It was predicated on catastrophic hemorrhage to start off with, which is fine if it's there, but immediately trying to find it in everybody is a problem. And you look at John Atkinson again as an example. He'd been moved, so no one truly recognized the catastrophic hemorrhage. It was then, okay, are you uninjured? Nobody knows whether they're injured or not at that early stage. Excuse me, sir, madam, are you injured? Well, I don't really know. My ears are ringing. I can't, I'm a bit sore here. That is taking time. Then paramedics were expected to just make the decision as to whether a patient is dead by simply opening the airway and seeing if they were breathing. No one said how long for, the stress that they're going to be under, and consigning a patient to death at that point. Some of them will be undeniably dead, but if you were unsure, when you face that legal scrutiny come the public inquiry, how did you check? I represent the family. How did you check? What did you do? That's an immense amount of psychological.
Right, let me stop you there, Phil, because the coroner's report says this. Oh, Jesus, right. Okay,
Yeah.
well, I couldn't see that,
And from a healthcare perspective, what is hardwired into you if you get to a patient, you open their airway and they are not breathing, you start resuscitating them. So all of a sudden...
And then you committed.
Yeah. all of a sudden you are having to go back on everything that you've ever done. So that was a problem.
For the general public listening, sorry. So are we saying my brother-in-law's a paramedic, so I've done a few ride-alongs with him, but it was hilarious some of the stuff that I was doing because I was obviously asking lots of stupid questions as a slightly glorified first aider in the fire service. But it felt like it's still on a similar theme to what the public might know as, your Dr. CABCs and all that jazz. Just a lot more kit, a lot more knowledge, clearly, a lot more training, but a similar theme. And if you've just said, if you get to airway and you're committed, if you get a catastrophic bleeding, you're committed, then you're like, you're in.
So
actually resource gone on that one.
So what we really needed was something that was simple and rapid. There was Professor Chris Moran set up an NHS England task and finished working group to revise what was the NASMED NARU triage sieve, which was the tool that was used by all paramedics or all ambulance staff at a major incident. And we got a group of really good academic people. We reviewed the evidence and we created a new tool, the major incident triage tool. And it was scientifically so robust. But we did something that hadn't been done before, to my knowledge, and we field tested it in a mock major incident. So we got a load of ambulance staff and we set up this mock major incident. It was a proper bad day at the office. We had deliberate vehicle attack through a pedestrianised area. We had people attacked with bladed weapons. We had some petrol bombs thrown, and then we had a person-born IED go off. It was a little bit Holby-esque in its, this is a really bad incident. But we found even under those exercise environments, the bandwidth of the paramedics was stretched. Counting a pulse, counting a respiratory rate. They couldn't do the maths. They don't wear watches anymore. So
why were we doing that? Because your own like intense, you're full of adrenaline and I'm going to touch
well, I
why
don't know.
Why were we doing that? Even with pulse oxes and stuff now, I'm like, why are we still doing that?
Well, I think we told people that that's what they would do, and everyone said, yes, that's what I'll do. And afterwards they said, oh, I did that. And I don't think they ever did it.
No, but people have got so many random complexities in their own bodies now, with where they've got Raynaud's, they've got poor pulses, they've got this, they've had a previous injury, and then to find out that stuff, you've committed another 8 minutes of questioning or 4 minutes of questioning. But then it's like,
the
Why are we doing
cognitive
pulse? You know, you
load.
see that still in films where
Yeah,
they're walking along with a gun, they drop a knee and feel
yeah,
the pull. Behave
yeah,
yourself. What are you doing?
yeah. You know, the cognitive load, the sounds, the sights, the smells, that emotional burden that will be going on, even if you're very experienced, will just be overwhelming.
Mm,
So, at the time that we'd developed that and went, well, yeah, it's great, but it's really slow. Myself and Claire Park, my colleague from London Air Ambulance, we had been working on triage tools for the police officers that we look after. We both look after discrete groups of specialist firearms officers, and we'd
nice.
thought they needed something that was quick and dirty. And she'd been working on one which involved um, checking out for penetrating torso injury, which is a likely cause of internal bleeding and, is a strong marker for you needing to be taken to definitive care
Mhm,
quickly. I'd been working on one which was basically very simple: walking, talking, breathing dead. Because anyone can kind of go, that patient's walking, that one's talking, that one's
mhm.
breathing. Not too difficult.
Yeah, that's what I think when I turn up to road traffic collisions. I'm
Yeah.
like, who's moving, who's
Yeah.
loud and quiet,
Yeah.
and then where can I see blood? And you know
And
what I
so,
mean? If someone's
as
really loud, I'm like, oh, they're fine. They're just making a lot of noise. I glance at them and go, is there masses of blood as well as lots of noise? If not, you're
yeah.
not being harsh, but you've got to be relatively brutal straight away and go, it's just noise.
So,
She's making noise.
So my very simple kind of, eyeball
Yeah.
list versus the one that Claire had with a focus on severe bleeding and penetrating torso injury. We kind of smashed those two together, and
Mhm.
we kind of came up with what turned in to 10-second triage. And we did a number of things that at first people kind of struggled to understand. So
Okay.
the first node in 10-second triage is the patient walking? And
Mhm.
people go, oh, but catastrophic hemorrhage is going to kill you. But if I am faced with, in that ratio of 2 responders to 300 people, I want to very quickly thin those numbers down to a number that I need to focus on.
Yeah.
So if you are walking, you must have a good enough blood pressure to be able to perfuse your brain and your
Yeah.
legs.
Because
Now,
people will go, yeah, but they could still have a crash. Well, if they are, they ain't going to be walking for long.
so
If
one
I watch them for 5 or 10 seconds, they're going to
yeah,
stop walking if they've got a catastrophic bleed.
but this is where we put in the common sense bit. If they are staggering and there is blood pouring out of them, please feel free to say, "Sir, madam, please be seated and allow me to triage you." Um,
Want to
so,
sit down or fall down? It's up to you.
yeah, yeah. So, we wanted walking first to thin down the numbers, with the caveat that if they are clutching their chest with a hole in it, you can get them to sit down. The next one was deal with the severe bleeding. We changed it from catastrophic hemorrhage to severe bleeding because catastrophic hemorrhage, everyone thinks blood pumping everywhere. It might just be slowly trickling out. And if you're there 15 minutes after this incident has happened,
Mhm.
that spurting blood may not be anywhere near as much. So we put severe
It's
bleeding,
more
and
accessible language, isn't it?
yeah,
Severe bleeding. Public know
uh,
what that is,
and
clearly.
if you've got severe bleeding, you deal with it as best you can. Now that may just be some direct pressure, get that done by a bystander, get that done by a colleague. It may be a tourniquet, it may be packing. It depends on what your skill set is. But at the end of the day, your job is to stop that severe bleeding,
Because hemorrhage is more of a medical word, really, isn't it?
isn't it?
It starts to get clinicalized and to
Yeah,
inaccessible. Oh, I
yeah,
can't do that. It's a hemorrhage. But
yeah.
it's severe bleeding. That's what it is. You know,
And and
really
and if
severe,
they
but severe.
if they're walking, they're a P3. If they've got severe bleeding, they're a priority one. The next node is then talking. Is this patient talking? And if they are not talking, you move on to the breathing node. But if they are talking, you do a very quick check around for a penetrating injury, somewhere where they might have an internal injury which is bleeding a lot. So that's chest, abdomen, but also remembering going down the sides, armpits, root of the neck, down into the groins and buttocks, areas where there's big blood vessels. And
Mm.
if they've got a penetrating injury in that area, they are a P1 because there's likely internal damage and bleeding going
I
on.
bet buttocks is often a hidden one, you know.
Oh yeah. Yeah.
Because it's
That's
straight
one.
into the hip cavity. It's still into the pelvic cavity where
Yeah.
you can lose masses of blood, but it's underneath you. It's out the way. You're sat on it, but
And
it's an
your
area that's
glute
not obvious that you've been
Your
stabbed
glutes
or you've
are
had a
big,
penetration.
hard-working muscles with a massive blood
Yeah.
supply, and people just do not comprehend that even if you don't get all the way through into the pelvis and start hitting the big vessels and the
Mm.
bowel and stuff like that in there, those gluteal vessels will absolutely spray blood everywhere, but you'll be sat on it,
And it can be absorbed all, like say, all into the seat, all into the clothing.
on the
It's such a
graft,
hit, and
wherever.
then all
Yeah.
into the pelvis.
Yeah.
Do you know what I mean? You can lose
Yeah.
a lot of blood and not see any of it, which
So
is crazy.
So then if, you've done the talking, and if they're talking, you check for the penetrating injury. If they're not talking, you go on to breathing. And if they're breathing, you roll them into the recovery position to open their airway, and they're a P1. If they're not breathing, you roll them into the recovery position and they're a silver not breathing, because basically, whether you're breathing or not, you are not consigned as dead yet. You still get a level of care.
Mhm.
Um, what is also very interesting is if you have got responders there or enough people to deliver CPR, basic resuscitation on these not breathing patients, why shouldn't you let them carry on with that? Only if you need them to go and triage more patients.
Mhm.
So we created this tool. We bounced it around a bit. It's not meant to be super scientific. It's meant to be quick and dirty. I always wanted to call it quick and dirty triage, but Prof Moran wouldn't
Yeah.
let me. So we came up with a 10-second triage as that
That is
kind of,
good branding, though.
yeah.
10 seconds triage works. That was good.
It was a proper advertising jingle, but more of that later, because that was an area of controversy. So we
Okay.
kind of went, okay, we've created this tool. It doesn't declare anyone dead. It could be used by any trained responder,
Mhm.
which is what we wanted. Because what we wanted was a tool that could be used by anyone with that basic first aid training of airway opening and stopping bleeding, because then it becomes a force multiplier instead of it just being 2 or 3, 4, 5 people from the ambulance service. It's every responder there that isn't actively doing something else. So
Mhm.
if you're police and you're neutralizing threat, that's fine. But if you're not actively doing that, let's get on and save some lives together, shall we, folks?
Mm.
Ditto from a fire rescue perspective.
Mm.
If you are there doing proper hazard management, that's your goal. You crack on. That's keeping us all safe. But if you ain't doing that, do you want to come and help me save some lives? And
Mm.
so it became a
How have
massive.
those conversations gone? Because just to connect a few dots, people will have heard it in the intro, but you've done clinical leadership for heart, so hazard area response teams. You do tactical and strategic command courses with NILO, so our National
Mm,
Incident Liaison Officers, which we see. So for people that don't know, heart is just paramedics. NILO is kind of all organizations, and NILO feeds straight into JESIP. Does anything get missed in your gap? Because we're leaping from like high, sort of a high pillar of each sector, and the
yeah.
JESIP bit is supposed to pull the pillars together, but something ultimately or often gets lost in the chasm when you
It
cross those chasms.
it does, and I think 10-second triage became an interesting example of how you blur those lines.
Okay.
Because we were saying, hey, it doesn't matter whether you're police, fire, ambulance, you can use this triage tool and save some lives.
Mhm.
And hey, look at that Jessup, the
Mhm.
pentangle of procrastination, or whatever people want to call it, at the center
Steady.
of at the
That's
at the
controversial. I like it though, and I agree. I agree. I had a guest on that spoke about decision vortexes, and it's
yeah,
very much one of them.
yeah,
Can be
yes.
if you don't have someone that is a slightly more assertive and not
Yeah.
so risk averse, because you
Use
can just keep going around that bloody thing all the time if you
Yeah,
wanted to.
yeah. You can just keep spinning that wheel, but using some of those decision controls about what we're trying to do, what do we want to achieve, what's the risks, what's the benefits, how does it sit with me? I think that bit is the valid bit. But everybody reciting their powers, policies, and procedures and quoting, I don't need that, because that's fine in a tactical or a strategic environment where you've got the time to make those very much more more type 2 thinking decisions.
Mm-hmm.
In that heat of the moment, you need something fast and naturalistic. Anyway, so getting back to 10-second triage, we tested the major incident triage tool, so we wanted to test the 10-second triage tool, and we had no idea how long it was going to take. So we set up the major incident exercise again. We used the major incident triage tool as like the control arm. We had a number of ambulance staff that we said, you're going to use this tool. We had police and we had fire at the incident, because you would have. And we said, hey, folks, you just do what you would do. So if you're, if you come across somebody who's bleeding and you've got tourniquet and you're trying to use it, use it. We didn't say to them, don't touch patients. We said, just do what you would do if you were at this incident.
Okay.
But we were crafty in the way we set up that exercise. So we had 40 odd patients there, but within that we had 11 patients that were index patients. They were based on patients that had been injured in UK major incidents, terrorist attacks, that kind of thing. We knew their injury pattern from their hospital notes or their post-mortem, and we knew they had a time-critical injury, which was either stopping bleeding or opening their airway for them to survive. So they were the ones that we knew needed those interventions done rapidly to have a chance of survival. So we set up.
When you say rapidly, how long did they have to discover these individuals and treat them?
Well, the exercise ground was covering about 400 meters. You had 10 responders, so they had to move around that quite quickly. And we know that people will bleed out in depending on the type of injury, somewhere between 2 minutes to 20 minutes. We know that if your airway isn't open, that you will start getting irreparable damage to your brain, probably at about 4 to 6 minutes, that kind of thing. So, we knew that those early life-saving interventions needed to be brought in very, very rapidly. So we did the control arm, which was the ambulance delivering triage and the police and the fire just doing what they normally did. And we found that in those index patients, the longest time from responders entering the environment to getting that life-saving intervention done was 20 odd minutes, and it was sort of like, that's not great. So was
that because fire and police weren't empowered with this as well? So they were just told to do what you'd usually do, and then the paramedics had.
And some of them undoubtedly saved lives. They were faced with severe bleeding and they dealt with it before the ambulance got there. So, we had these index patients. They were timed as we were crafty. We used paramedic science students and medical students to be the patients, so that they could time when they had it done. So there wasn't somebody over them with a clipboard, because that's not how it works. You don't have that.
No, very good point though. Yeah.
So we then took this group of fire, police and ambulance people, and we got them from all over the country. We just reached out for volunteers. We had people from northwest, southeast, southwest London, everywhere, and we gave them the talk on 10-second triage. My colleagues Claire and Sean Harris gave the education on it. And we then said, right, we're going to redo this major incident. And we moved the casualties around a bit. But what we did was we went, okay, we're going to have 10 ambulance go in and do it now. So same number of responders, see how long it takes. Then we'd reset and we'd do 10 police, and then we'd do 10 fire, and that, that kind of thing. And we were just looking how long it took for them to complete all the patients, triage them all, and do those life-saving interventions in those index patients, the ones that we knew really needed it done quickly. But the thing is, we had no idea how long this was going to take. We'd seen that it had taken about 25 minutes for the major incident triage tool to be run through. And the first run was over in 7 minutes. And we went, what the hell happened there?
Yeah.
we reset it and we repeated it, and we found the time to triage drop down dramatically. But you had the same number of responders, but they were just using a process. And
Yeah.
the time to those life-saving interventions in those time critical patients went from 22 minutes down to 6 minutes. Now that is potentially the difference between life and death in a
That's
salvageable
not a
patient.
marginal improvement, is it? That's a
No.
fairly colossal gain.
And what was we then did a couple of sessions of the same incident, but with a mix of police, ambulance, and fire working together.
Mhm.
And what we found is, because everyone was using the same triage tool, they were speaking the same language. What was a P1 to fire was a P1 to police, was a P1 to ambulance. And they developed confidence in the other services' decision making because they were all using the same tool. We also found that it gave those responders who are not used to the concept of triage, as in doing something and moving on. They had now a tool which gave them the authority to say, I've done everything that needs to be done, that would be done by a paramedic, and I can now move on to the next patient. So it empowered them to start dealing with multiple patients rather than feeling they had to sit with somebody and wait until Team Green arrived.
Mm.
So we got not only those quantitative changes in the time to life-saving intervention, but the qualitative changes about that shared situational awareness, that shared language, that common understanding, the simplicity of it. And we use colleagues from UK HSA Behavioural Insights team to kind of write that qualitative bit up, because I think for me, it's not just about those hard numbers. It's about how does it feel? How easy is it for a responder under a very high stress environment with massive cognitive load when your bandwidth is so
Mm.
shredded? How easy was this to deliver? And everyone loved it. So what was very opportune at that time is we'd been working on this, myself, Claire, Sean, Jamie Vassallo, and a little tight group of us had been
Mhm.
working on this. And we were slightly amazed by how quick it was.
Mhm.
Um, and this was at the time that Sir John Saunders was writing up the Manchester Arena inquiry,
Mm.
when Claire and I gave expert evidence in I think it was the January or the February. We were in the very early stages of developing what turned out to be 10-second triage. But by the time he was coming to write his report for the November, we'd done all the field testing. So I was able to give him the information about how quick this was, how it was equally as quick and effective in the hands of police, fire, or ambulance, because we did a inter-service comparison. And
Mhm.
I'll spare the blushes of my colleagues in green, but they ain't that quick and they ain't that good. Um,
Okay.
and we were then in this situation of Sir John put it into as a recommendation within the
Yeah.
monitored recommendations, and he said this will make a difference and it must be adopted by all agencies. So all of a sudden, when you're facing that organizational monolith of College of
Mm.
Policing, MPCC, NFCC, all National Ambulance, medical directors, all of those august organizations, all of a sudden we were able to walk in with and here it is as recommended by Sir John in the Manchester Arena inquiry. And everyone bought into it. And I think they bought into it, one, because it was written down as a recommendation, but two, they could see the evidence that it was
Mhm.
patient centered, it was quick, and it was simple. And so
It
it,
was deployable, yeah. It
yeah,
wasn't too held up in,
yeah,
academic language and
yeah,
complexity. It had
quick
been
and dirty.
designed, as people
Yeah,
will see from the first responder sector, they're very, very familiar with 10-second triage, but it's actually survived conflict. Do you know what I mean? They
yes,
always say, best band doesn't survive first conflict,
yeah,
but this sort of thing had, and it's
yeah,
very deployable because it's knowing that, or having the confidence and the academic support now that slow accuracy can kill more people than fast imperfection. Not that
yeah,
saying the imperfections, but you know what I mean? It's like, don't make great the enemy of perfect, because a
Yeah.
utopian answer is only going to happen in a clinical environment at the hospital. And
Yes.
it's knowing that not all of that's going to map over.
And I often use when I kind of lecture at conferences, or speak at conferences and lecture on triage. I give the clinicians the choice of, what tool do you want? Do you want something like an operating robot which costs millions of pounds, takes 2 years to learn how to use, but is accurate to 1 or 2 microns? Um, do you want something that sensitive and specific, or do you want a Stone Age axe, which has just got a handle and a lump of rock on the end, and you don't need any training to learn how to use that? You got a handle and a hitty end. Pick it up by
Yeah.
the handle, hit it with the hitty end,
Monkey
and
see, monkey do.
yeah,
And that's
there
what we
is.
are. I always refer to us in the fire service as really, 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 really passionate, just knuckle draggers. They're my words. Not that everyone's a knuckle
Yeah,
dragger, but that's what we started as, most of us. Lots
yeah,
of desire, lots of interest, but we don't need a doctorate or even a degree to join the
yeah,
fire service. That doesn't make us stupid. It just means we're not academic.
yes,
There's a high level of intelligence in the first responder sector, including the fire service.
yeah,
But because it doesn't necessarily always come from an academic side, you need a degree to be a paramedic. I think you also need a degree to be a police officer, but you don't need one to be a firefighter. So these things, if we're all going to work together,
yeah,
we can't we
and
can't lord our academia over other people and then go, "Why are you not doing it?" Well, it's bloody complex, Phil.
yeah.
Where's the easy version?
But I think the other thing is, from a health perspective, we're our own worst enemy as well, because we go, oh, but it's not very sensitive and very specific, and this might happen. It's like, I don't care. We can come
Mm,
back to that patient once we've done those early life-saving interventions. So, the biggest problem we have, I think, from my experience of seeing it used at exercise and moderate
mhm,
size incidents, is health want to be health and too clinical about it. What you actually want to do is just sack off your clinical acumen for the period of 10-second triage. And once 10-second triage is done, then you go, right, now we start thinking about these patients, because I know how many P1s, P2s, P3s, and silvers I've got.
mm,
Now I can get people start focusing on that. And I think what we're finding from instance like Southport and Huntington, Manchester Synagogue, where 10-second triage has been used, it's what comes after 10-second triage that is actually the key bit. And
mhm,
that's where you really need that clinical aspect of healthcare response, looking at those P1s, because you could be a P1 for lots of different reasons. It could be
mhm,
because you're not talking because you've got a closed head injury, or you're not talking because your blood pressure is very low, or it could be you're a P1 because you've got penetrating torso injury. You may deteriorate very quickly. You could be a
mhm,
P1 because you've got severe bleeding from your arm and somebody's put a tourniquet on, but hey, could we put a pressure dressing on and take that tourniquet off? And
mm, mhm,
that's now controlled. You're no longer a P1. And so for me, from a health perspective, what the clinicians have to do is find the P1iest of those P1s, the ones that need to be pulled out
mhm,
and get straight to hospital as soon as possible.
mhm,
That's where health comes in. So interestingly enough, in the way I've seen, if 10-second triage is being delivered well, the best occasions is probably when there is a mix of responders delivering the actual TST, and then health come on top of that to start reprioritizing once
mm,
life-saving interventions are done. That's
mhm,
that's the bit that I think we need to start really working on. But
mm,
the I think it's just worth thinking about the 10-second triage, the title of that I came up with that as like an advertising jingle kind of thing. 10-second triage, it
yeah,
sounded kind of funky.
mhm,
Oh my word, what an absolute Marmite event that was. So you got some people kind of going, oh, 10 seconds. So does that mean at 10 seconds I must stop treating that patient and move
yeah.
on? Or I must spend 10 seconds with each? And it's like, no, no, just look, the ones
I
that are
wouldn't even
walking,
answer them.
you know, that, that you have triaged them in, a microsecond. The one that needs 2 tourniquets, well, you're gonna spend a bit longer with them, and you may spend more than 10 seconds,
Mm-hmm.
to apply those tourniquets and stop that catastrophic bleed. But, come on, folks, and, that torso
Because
check.
unknowingly, in the first a couple of seconds, like 2 seconds, you've probably already made a decision
It's
anyway.
it's
You've
just
already
doing
pattern matched, and now you're spending more time looking for confirmation bias as to
yeah,
why you think that is. You're already heading down. They've
yeah,
clearly not lost their head,
yes.
and
So
they're not covered in blood. So
so
you've seen
yeah.
those things from 30 feet away.
Yeah,
Do you
so,
know what I mean?
if there's blood pouring out of them, I've triaged them at that point. It's the life-saving interventions that are gonna take a
Yeah.
little bit of time. So,
Yeah.
this was turning into a real, Marmite moment, with some people going, "Oh, no, because, does it mean that 11 seconds I have spent too long?" It's like, "No, no, no." But the fascinating
Yeah.
bit, and, when we did that field test, we looked at the average time to triage each patient. So,
Mhm.
looked at the time duration that the responders were in there from the time they entered to the time they finished, the number of patients they'd triaged. And for 10-second triage, the average time over all of those patients, and bear in mind we did it so many times, we had hundreds of data points there, was 10.2 seconds per patient. And it was just like, boom,
Boom.
Ron Seal, quick firing wood stain of triage. It does exactly what
Yeah,
it says on the tin.
yeah. Because when I mean, someone might do the maths listening to this, but if we said on that one you spoke about, like 7 minutes divided by 40, and there will have been some that were shorter than that, some that were longer than that, and they go, yeah, but for that person they took 20 seconds. Yeah, but the average over those 40,
Yeah,
and you go, because you quickly glance at 5 people clearly standing by the road,
yeah,
and you go, well, they're not in it. So,
yeah,
and that was what? That was zero point 0.5 seconds per
yeah,
person
yeah,
or whatever. This person's sitting on the floor. Hey, turn around
yeah,
for me. Yeah. Oh no. Okay. Right. Yeah.
yeah,
Do you know what I mean?
yeah,
So yeah. That yeah. When you zoom out and look at it holistically, and we
yeah.
are talking mass casualty incidents,
Well,
you know. Well, no, it's applicable to any, but
yeah. So
certainly the 10 seconds, the bigger and bigger casualty number you apply that to, it probably
the
gets shorter than 10.
yeah.
To be
So
honest.
we created this for that moment when you are the one or two responders and you walk into carnage.
Mhm.
Um, but we found it was so effective. It works if you are one or two responders turning up to a 5-patient road traffic collision, because you can just do that very quickly and then come back. We had a lovely example of, just after we'd done the field test, we had a big road traffic collision in Bristol. A vehicle had crossed a piece of the central reservation of dual carriageway and hit another 5 vehicles on the other side. And there was 16 or 17 patients involved in this incident.
Mhm.
And fortuitously, there was a police public order serial in their van that had just come back from a high risk football match, and they were first on scene to this. They'd all come along to the 10-second triage field test, so they were all trained in it. And they had triaged, using 10-second triage, every patient before the first ambulance response arrived on scene. So when the first ambulance response arrived on scene, called in for some backup and said, "This looks big, we're going to have to start triaging the patients." The police sergeant went, "We've done it. There's the list of how many you've got. You've got 4 P1s there, some P2s there, and all the P3s down there."
Mhm.
And it was just like, oh, wow.
Yeah.
And it just shows how quickly and effectively it can be done.
Mm. There's so many areas I see that I know it was heavily praised from the ISAR community, the International Search and Rescue community, because when they're doing large area,
Yeah,
searches and like an initial sweeps of areas, you get into a building, you get onto a bus that's been involved, you get onto a train, you get onto
yeah,
an aeroplane where there's just one or two of you, or there's teams of international search and rescue operatives, most of them carrying kit, and there's 10
yeah,
or 20 of you walking into an area of 400 people.
yeah,
And you go, right, we need to walk through or across these buildings. We need to say no to a lot of people. We need to keep moving, but we do need that exact kind of thing.
yes, yeah,
Perfect. And they were really appreciative of the
yeah,
work that's been done in this sort of thing. One of the things we did have on our list, which is heavily embedded in my world / our world, obviously similar worlds, but slightly different. Is this aspect of hot zones, cold zones, warm zones? I was at an incident recently where it's sort of hazmat, and we're talking about cylinders, and then we're also talking about like gas clouds and different examples. Very vague,
Yeah.
as in how big is this blast radius? How
Yes.
big is this? Now, those things arguably are more quantifiable because they have a chemical element to them. But when it comes to civil unrest, or when it comes to an active shooter or a bomb or not bomb, is there a secondary device? Is there not? How do you think about zoning, and is it net positive, or do we create invisible lines in our head that become more of a barrier?
I think the concept of zoning has been with us for so many years that we've tried to latch everything onto it.
Okay.
So from a zoning perspective, I kind of get it from a CBRN and hazmat
Yeah.
situation. That stuff obeys the laws of chemistry and physics, and it will behave as such. When it comes to marauding terrorist or armed active offender or whatever you want to call it, I don't think it works.
Mhm.
These are dynamic, very dynamic incidents. They are over in sub 10 minutes, the vast majority of them. Trying to work out where is hot. Well, if they're marauding terrorists, guess what? They move. And what was hot is probably no longer hot. What was warm could be hotter, or and how do
Mhm.
how hot is hot? How warm is warm? Is it lukewarm? Is it tepid? Is it
Yeah.
just off the boil hot? Is
Yeah.
it cold? Is it ice cold? And nowhere is cold.
And the delay that gets communicated in, which is a
Well,
barrier that's still stopping somewhere
so
else, like fire in the Manchester examples.
so every incident that I have looked at and every exercise I have attended, the zoning has caused patient harm because it has increased that care gap. People don't know where they can go. Or who's allowed in the hot zone? Who's allowed in the warm zone? How warm is that zone? It is dynamic. It is disordered. The whole thing is disobedient. And what happens then is, in this view of ensuring responder safety, we will say something like, okay, there's an attack in there. I did an exercise at a football stadium, 65,000 seater football stadium, 3 people with bladed weapons in one of the stands attacking people. And it's like, the whole stadium is hot. And it's like, no, it isn't.
Yeah.
I can see where they are. Now, if you've got 3 assailants with AR-15s, I grant you that's a little bit different, but bladed weapon,
Mhm.
come on. I
Mhm.
could be within, I'm probably no more than 10 foot away from a knife every time I'm out doing
Mm.
pre-hospital care, at
Mhm.
certain times of the day. But if I've got 4 firearms officers between me and them, I'm
Mhm.
I'm very safe here.
I think of this example, so just to go on a segue to keep other sectors with us, bridgeheads
Yeah.
in high-rise buildings. People go,
Mm.
"Oh, bridgehead needs to be 2 floors below the fire." And I come at a different angle. I'm like, "No, there needs to be kind of 2 bits of separation, fire separation between you and the
Yeah.
fire." Now, you could actually be on the same floor, and that just could be 2,
Yeah.
2 compartments away from you, because it could be a really long hospital. Do you
Yeah.
know what I mean? But if you stayed rigid to 2 foot, well, you could be bloody miles away from being able, not miles, you could be a long
Yeah.
ass travel distance away from doing anything
Yeah.
to that fire. And is your BA going to last that far? It's similar. So just as a similar
Yeah.
analogy for people to
And
hold it with them, like you say, that's a knife. It's not going to move fast like a bullet. Do you know
yes.
what I mean? Hot zone in the water. Okay, 3 meters away from the water's edge. It's a river. It's not going to
Yeah.
move really quickly and jump 6 meters in this. It's the edge of the
Yeah.
water. Do you know what
Yeah.
I mean?
And the problem is, these zones get made very large, but then there is a
Yeah.
failure to shrink them
Yeah.
down and de-escalate them. Um,
Mm.
we've, if you look at the inquiry report from London Bridge Borough Market,
Okay.
it criticised the size of the zone, the understanding of
Do you
who
recall
could
how
go
big
in.
it was?
It was pretty much all of Borough Market, and it was like, well, that's a rabbit warren of
With
places.
many thousands of public in it.
Yeah.
So we're
Uh,
writing them all off, are we?
you know, Manchester, conversations around the zoning about, but there might be an IED. There might be an IED, but turns out there wasn't, and it will take us hours to know. The Westfield shopping centre in Bondi was fascinating. So,
Okay.
solo knife attacker within the shopping centre stabbed 16 people in just under 3.5 minutes. There was victims over 3 floors. Thanks to the forward-leaning approach of New South Wales Police and the ambulance service, a lot of those patients have got to. And the rapid neutralisation of threat by Amy Scott was just incredible. And that then became a theoretically entirely permissive environment. But there was debate about whether there was a second attacker, and I completely understand that. That's a large number of people stabbed in a very quick period over a number of floors. You can't comprehend that one person could have done that. So is there another threat? But responders went in, so police and ambulance went in together, and said, "Come on, let's go and save some lives." And that there was lots of bits we could applaud as a result of that, but there was a fair amount of learning. But what happened was, sometime after that, the threat had been neutralised. There was a failure to adhere to any interoperability principles, so there was a failure of information sharing between the police and the ambulance, and an ambulance commander called it hot sometime after the threat had been neutralised, even though the police had confirmed evidence from CCTV. There was no second offender, that the environment was as safe as it could be. That resulted in the withdrawal of all of the responders. Thankfully, they had got to all of the salvageable victims by that point, but there could have been people in shops that were hiding. There could have been, that was a near miss. That hot zone, once declared, stayed on for hours because no one ever rescinded it. So I think we end up with a problem with this proscriptive zoning. We need to think about where is the immediate, the dynamic risk assessment of what's in front of me, and an understanding, like we discussed earlier, that if you've got trained and protected responders, they should be going forward into environments of which there is a degree of risk to save life. Because if bystanders are there, we have a moral duty, I think, to be there and look after them. So, I think zoning causes us more problem. And I think if you look at incidents where zoning was not undertaken, and you could argue that at Huntingdon train stabbing and at Southport zoning was not undertaken, we end up with unexpected survivors because responders are in there. If you look at Westfield Junction in Bondi Westfield Junction, because of that rapid deployment, early life-saving interventions and rapid extrication of high-priority patients, they ended up with one incredible unexpected survivor, which was little baby Harriet, which was a stabbing through the abdomen with bowel contents hanging out, peri-arrest.
Jesus.
And she was picked up, put into an ambulance, access was gained. She was given some blood product and a little bit of inotropic support to keep the blood pressure up, and she was in theatre within 34 minutes of the injury. Now, yes, it's a metropolitan environment with a lot of big hospitals around, but that was about that. We're going to get in there early. We're going to find the high priority patients, and we're going to get them out to definitive care. This is where I say it needs to be centred at the patient, not at the dogma and doctrine that goes around it. We say, we're coming into spring now, and in summertime there will be all these bits on the news. Dogs die in hot cars. Emergency service responders, police, fire will be called to dogs in hot cars. Expectation that
And people swimming in open water.
But if dogs die in hot cars, patients die in hot zones. That's where the harm is, and we need to somehow either stop calling it a hot zone or get responders in there to save some lives.
So the getting the responders in there, I want to be conscious of our time because I know we're wrapping up, but is there an element here to echo back to our American colleagues? You do clinical governance for police specialist units as well. Do we need a higher level of armed response to guarantee a more ultimate level of safety for the paramedics and or fire who are supporting or seeking to get into those areas to deliver critical care? Because if the police officer's just got a taser and a loud voice and a hitty stick, I'm not being facetious, but
No.
I'd feel a lot safer with a police officer with a gun next to me if you're asking me to go in there with them and do stuff.
Yeah, I think it depends on.
But also, we don't want to see thousands of guns on the street. You know,
No.
there's a
There's
and is the threat of someone with a with a knife? But even then, I'd quite prefer. I really want to stack the deck in our favor when it comes to protecting first responders. I don't want it to be an even fight.
Yeah,
You know, I don't,
yeah. I worry about the proliferation of firearms, and I
do
think
as well. I know.
If I am faced with a threat with somebody with a bladed weapon, be they of a malicious intent terrorist ideology that wants to seek out victims, or they're just a nasty person, or they are tragically mentally unwell, like Joel was in Bondo shopping centre, I think a degree of protection by officers, 3 officers with tasers and asps, I'm sure can keep that person at bay long enough for me to get in there and get a patient out. Now, if that threat that we're facing is a firearms threat, that is a very, very different environment. So I think we need to be a little bit more balanced as to what the threat is. And I think we get this in MTA, marauding terrorist attack exercises. Everyone says, oh, well, they've got AR-15s or AK-47s. And it's like, okay, that is unlikely. It's possible, but it is unlikely in the UK, and it will happen at some point. We have to acknowledge that.
That's what I mean. I don't know. I just feel like we both have a number of friends in the police. I'd rather just trust them to shoot to neutralize or disarm.
Absolutely.
I don't know,
Yeah.
but I trust them.
Yeah.
There's a lot of distrust for the police, and I think it's unwarranted.
Yes,
Very unwarranted. We
I
take these political beach balls of horrible incidents happening in other nations and throw them around to beat the police with. I'm like, no, that's no.
I think what was fascinating in the Bondi one was Amy Scott went in there and shot Joe, and she did it within a few seconds of arriving on her own. She walked in, and yes, she's armed, but just with one Glock. She's that's what they have. But she did a textbook delivery of confronting, challenging, and when attacked, neutralized the threat. Then called it in and very rapidly got onto resuscitating Joel. But there wasn't.
We need to tell that good news story more.
Yeah.
Because there's 20-to-1 ratio of people ready to say the police are just out there.
Yeah.
Whether they're racially driven or horribly driven or whatever, and they're there trying to shoot people. No, they're not. They're not. Yeah. All right, stop.
No. No, and I think there is definitely something that we need to be able to work with our colleagues. But similarly, I don't want police saying, oh, you cannot come in here at all until we have neutralized the threat. No, I need to be close behind you because that's where the patients are. The patients
and
are
also for you to echo back to our, I want to be able to be there for you.
Yeah.
Echoing back to the 2 police officers that died, because you might become injured.
Yeah.
I want to be respectful of our time. We are both gonna, part of the reasons we met as part of the advisory board for this Blue Light show, and it's really very much an echo of the conversations we kind of already had on the podcast. And I love meeting interesting people like you. It's been a privilege to have this conversation, but there's going to be many more of these types of conversations because people will have been listening going, how come we didn't ask Phil about this? How come we didn't ask Phil about that? Well, because I'm imperfect and I forget stuff and I get too excited, Labrador energy, and go off down the rabbit holes. But we're going to be having so many more of these conversations. Why did you choose to get involved? It sounds like a stupid, obvious question because the blue light show is basically a wider analogy of the work you've already been doing for years. But why are these types of events so critically important?
Yeah, I think you've nailed it there. This is about the philosophy of doing our job, saving lives,
Mhm.
and looking after ourselves, and making sure we can deliver that care, educate the people that are coming behind us. And I think anything where you get both strategic leaders that can start making change and grassroots practitioners that can start delivering change,
Mhm.
having some of these tough conversations that we often don't have together
Mhm.
about, you know, taking risks, making decisions in high stress situations, how we can truly work together to get best patient outcomes, but also look after our responders. And the Blue Light Show last year, the inaugural one, the diversity and the breadth, but that common theme about
Mhm.
we are here as a emergency service family to
Mhm.
do the best for the people that we serve. Now, that's the patients, the public, but also our responders. And we
Yeah.
need to all properly try and take learning from each other and
Mhm.
share thoughts to just make this a better way. And, you know, no matter how many exercises you do, um, there is still nothing that beats the fact that you've had this conversation, you've thought it through before, you are not having to make it up on the hoof. You've mentally modeled what you might be thinking. And for me, this is, not just about the practitioners, the middle management and the strategic bit. It's about that whole philosophy of the services.
I think you don't want to be having those first conversations on the
Yeah.
incident ground. You want to meet your emergency services, your first responder family
Yeah.
before that. Do you know what
Yeah.
I mean? They say you don't want to learn to dance once the music has started.
Yeah.
Have these conversations here. I think of the Blue Light Show as crowdsourcing knowledge
Yeah.
because a lot of these conversations, you've been having them for decades in
Yeah.
closed rooms.
Yeah.
In back with the important people, not because you maliciously wanted to keep secrets, just because that's where they existed. They
Yes.
were on the incident ground and they were maybe over Teams and they were in the back office on
Yeah.
a debrief. It's dragging. Don't make assumptions that because you were there and you've had these conversations before. Everybody knows they don't know. They just
Yeah.
don't know. Not because
And
they're lazy, not because they're not professionally interested. They just weren't there.
and
So let's bring it into the public space.
And I think we need to start grasping some of those more controversial and difficult
Mm,
topics that we often don't. Be that about responder well-being, how we support them after an incident and through the inquiry and all of those bits, but also challenging something of what we've done before. Just because we've always done it that way doesn't mean that it's right. And I'm not saying that some of my perhaps people will view them as a more radical ideas aren't necessarily right. But I want to have those professional, curious, critiquing conversations about, hey, couldn't we do this better?
mhm,
And for me, if you put the patient at the center of it, that's what we're there for. Don't worry about your SOP, your guidance, your this, that, and the other. Was I doing the right thing to save lives? And
yeah.
then I think we need to be better about supporting people in making those decisions. And we can only
Mhm.
start doing that if we start sharing ideas and chewing the fat over it.
Mm. Stress test those in real life conversations. I love it, brother.
Yeah.
So we're going to see each other there. We'll be there 1st, 2nd of July at the Olympia in London. Hopefully, we'll have many more excuses to get together before then. I think we've
Oh, yeah.
got maybe 1 or 2 more advisory boards. And
Yeah.
I still need to buy you dinner in London at some point in time. We keep threatening it,
We do.
and then
Yeah.
life gets in the way. But
Yeah.
send my love to the family, brother. I really do appreciate your time this morning.
Thank you for
I
your
look
time,
forward to seeing
Pete.
you soon.
Absolute pleasure as always, mate. You take care.